Appreciative of her visit with us. Dr. Sear's trained in internal medicine and endocrinology at the University of British Columbia in Vancouver, Canada. She then went on to do further training in the field of inborn errors of metabolism before opening the first independent center in Canada for adults with inborn errors of metabolism in 1999. The Adult Metabolic Disease Clinic at Vancouver has grown to follow more than 1,500 adults with various metabolic diseases as one of the largest such clinics in North America. Dr. Sear's has been involved in a number of clinical trials and is one of the 5 principal investigators of the Canadian Fabry Disease Initiative. And I feel that even though our healthcare system barriers are there in terms of transitioning and other issues compared to Canadian, but after listening to her lectures and reading her work, I was always fascinated about some of the things she has tried and the lessons we can learn from her. So it's with great pleasure and honor I ask Dr. Sear's to share her expertise with us.
Great. I think I have to put the lapel mic on too, so let me take a second. Actually, it's a mutual admiration society. When you do inborn errors in adults, you know, most of the time you fly by the seat of your pants, like, let's face it. And I can tell you that over the years, there have been many times when my team and I have been looking at blood work or a clinical situation and haven't had a clue actually what to do, and everyone would go off and do their research and whatever, and many times when we got information back from Dr. Singh that made us all breathe a little easier. Anyway, sometimes it's just to say that she also didn't have a clue. This can be very helpful coming from someone such as her, but also some more concrete information. Thank you for asking me to be here today. I must say I'm a little bit frightened based on some of the conversation that I've heard earlier. Some of you may not agree with some of the things that I have to say. I'm starting off with a quote that was actually on the, let me just see, can I make the pointer work? What's that? The right arrow. Oops, no. I want the pointer. Anyway, the quote, adult care is not bad, it's just different. And this is actually something that was on the front of our transition books for more than a decade at our children's hospital. And this is, I think, a focus of some of the things I'm going to speak about as we move forward. As you've heard, I do run what is really a very large clinic now. I think we just hit 1,700 people with inborn errors of metabolism, and we've been doing this for a long time. Also, what is different about our clinic, based on some of the conversations that have been held today, is it is completely freestanding. Okay, so we're in a different facility. We have completely different staff. We have different dietitians, different nurses, different doctors. And it was actually, as a freestanding clinic, I believe might have been even the first in North America, certainly based on a survey of adult metabolic centers that was done a couple years ago through the Society for the Study of Inborn Errors, the SSIEM. Ours was the second largest at that time after the clinic in London. And of those 1,700 people, about 80% of them have been new referrals. Okay, so as geneticists, this does not surprise you that much genetic disease, including inborn errors, comes in adults, but also about 20% to 25% of them are people we've taken in transition. So we've spent a lot of time looking at transition, and I'm going to talk today really about barriers to transition and some of the literature on that. We're going to talk about how it might be difficult to generalize these to inborn errors using PKU as your biggest example, and then I have. When I gave this talk at the NIH afterwards, I was deluged by people trying to point out the errors of my ways and asking me many questions, like how did we actually set up an adult clinic? So I'm going to share some of that information with you today, although as I say, I do so with some trepidation. So you've already heard that transition is not an event, but a process, okay, that involves addressing all of the needs of the person as they move through their adolescence and into the age which the literature refers to as transitional age youth, depending on who you read. This is anywhere from 16 to 25, although we hear 30 may also be appropriate if you're thinking about someone becoming an adult. You've heard a lot about the medical home. And so if you look at the dates of this literature, you see that actually transition has been a focus for more than 2 decades. And we know ultimately what we want, something like a medical home. And believe it or not, there's actually a fair bit of consensus amongst healthcare providers. I say believe it or not because there was some very vigorous discussion today. But I'm just showing you one such study. This was done in Sweden, and they actually got every single endocrinologist in Sweden together. It's a very small country, so I guess that was a really bad day for blood sugars. But they got the adult and the pediatric endocrinologists together, and they came up with some sort of fundamental points, which are echoed in literature on other diseases as well. I'm only going to point out a couple of them here. Number one, they universally said that transition could not be done under the age of 18. In fact, for many diseases, 18 is certainly much too young and developmentally inappropriate. But I bring this up because I know in many places there is increasing pressure on the pediatric facilities to lower the age at which you transition someone or transfer someone to adult health care from 18 to 16. And I think physicians have to really resist this. Developmentally, it is clearly very inappropriate. The other thing which I find as an adult physician really interesting is that it was actually agreed that there was an ethical responsibility of the adult physician to make sure that once the patient had come to them, that they did not actually drop out of care. We've actually heard about the challenges of this already from Dr. Ekman. This is certainly something I see. This is completely contrary to normal adult practice, okay? So in normal adult practice, if you went after someone 3 times, 4 times, this would be considered harassment. Okay, or in the jargon of medical ethics, it would be considered a profanity, which is known as paternalism. Okay, but when looking at the issue of a transitional age youth, this was actually thought to be appropriate, and I must say it is actually how we operate. We go after them with everything that we have. So we've had more than 2 decades of research on transition. We know what we need to do. We know where we need to go, and yet, as you've heard today, we're doing it very poorly. This is a study published last year where they looked at patients with chronic health conditions and found that in the United States, less than a quarter of them were receiving the transitional support that we need, what was recommended. So we know what to do, we know how to do it, but we're not doing it. Why? Because there are a number of barriers to transition. And when you look at, there's quite a lot of literature on this, and you can sort of summarize these barriers into patient-specific barriers. One of this is that they like their pediatrician, okay? They've been with them for a long time. They're very anxious about their adult doc. Their adult doc, for example, doesn't have toys hanging on their stethoscope, might wear a tie, although actually adult physicians almost never wear ties anymore because of the germ thing. They have no knowledge about the adult system, and certainly there's widespread parent preference to remain in the pediatric system. This does not surprise me at all, right? The difference between the adult system and the pediatric system is, it's like driving a Dodge versus driving a Ferrari, let's face it, okay? So, but these are the barriers that the patients and their families discuss. In terms of the physicians, lack of specialists to refer them on to. Okay, this has been discussed today, and I'm going to come back to this. This might be because the physicians don't know what to do, or it might be because they're not willing to take on the care of somebody who requires a lot of support. Just as the patient is attached to the doctor is also attached to the patient. And I think particularly in the field of inborn errors, this is something that I think plays a much bigger role than in other parts of my life, like diabetes, for example, right? The endocrinologists are thrilled to punt somebody with diabetes when they turn 18. The adult hematologists are very happy to send someone on with thalassemia, but this is different with geneticists, I think. And I think, it might be because you have spent the last 18 years sucking that person with a urea cycle defect back from the jaws of death. Right? Over and over and over again, right? You are invested in this patient, and this is, I'm not saying it's a bad thing, but I'm saying it is an issue in terms of transition. And it takes a great deal of time, as we've heard, to coordinate the transition care. So if you bring all those together and you want to move forward, first of all, you have to clarify expectations, and this is of the patients and families, but also of the doctors on both ends. And I'll discuss this. You have to facilitate communication, both with patients and families and also with physicians. And in order to get the resources that you need to actually do transition the way it's supposed to be done from the age of 10 or 12 and all the way through making sure that follow-up is maintained, it has to be sustainable. And this is in terms of funding for resources, healthcare providers, and data that transition appropriately planned transition processes actually influence outcome, okay? We're going to come to all of these as we go through. So let's start first on the expectation. And again, I'm sort of summarizing from a whole bunch of literature, and I will actually tell you some of the things that we do at our clinic. There is a saying in pediatrics that children are not small adults, but adults are not large children, okay? They are completely different. The physiology is completely different. And although this sometimes is not a popular thing for me to say, in many inborn errors, once they hit adults, the issues are much more about the comorbid disease than the primary disease. Let me give you an example. You're an adult with glycogen storage disease type 1, right? They're no longer hypoglycemic all the time. They eat in the day. They take cornstarch before bed. So a person actually wouldn't have to know very much about glycogen storage disease type 1 to make sure that that patient was safe. But in adults, what are we dealing with? We're dealing with insulin resistance. We're dealing with osteoporosis. We're dealing with nephropathy, kidney stones, gout, dyslipidemia, hepatic adenomas, right? So that actually if you have an adult physician who knows a lot about that, and there's many adult physicians out there, even if that person does not actually know a lot about glycogen storage disease type 1, that person still can help you with their hepatic adenoma, still can help you with their osteoporosis. And I see Dr. Anderson shaking his head, so I'm getting prepared for the questions. Also has already been brought up, the issues in adults are not just medical, but social and economic. And these parameters, not that this doesn't also apply to children, but these parameters are different in adults, right, who no longer have their parents to look after them. And so again, some knowledge about how to deal in the context of not having parents to look after them. This is actually really valuable. Pardon me. I think this is also particularly relevant to the patients with inborn errors, many of whom, you know, they sort of fall through the cracks, don't they? They have IQs 80, 85, right? So they don't fit the criteria for, you know, mental retardation or whatever a person wants to refer to it at the current time, and therefore they can't get resources as someone, for example, with an IQ below 70. But there's no way that somebody who has an IQ of 80 could ever manage a diet with a urea cycle defect on their own, right? They really actually do fall through the cracks. And again, some knowledge of the adult healthcare system in terms of how to navigate those cracks, that is actually necessary. From the adult healthcare point of view, you actually do have to modify your practice. You need to do well patient visits and build a little rapport. Adult physicians do not do this, okay? So you know, we're not looking for work, and when somebody has a problem, then they can come in and see me, and when they don't have a problem, they shouldn't come in and see me. This will not work with this population. You have to see them on a regular basis, and you cannot actually cut the parents out entirely, even when the patient, for example, wants you to, and I'll talk about strategies about that. In terms of clarifying expectations of patients and families, there are data from the kidney disease population that it takes at least 5 visits to become comfortable with a new physician. So give them a chance, you know. I mean, shoot, yes, you're comfortable with your pediatrician now, but you weren't comfortable with them 18 years ago when your child had a pneumonia of 400 micromoles and that was in coma, right? You weren't comfortable then. Give the new physician a chance. Open your mind to the idea of healthcare providers who are not expert, okay? Just because they don't know something about glycogen storage disease does not mean that they cannot actually do really good things for your osteoporosis. And there also is a focus on non-physician healthcare providers, which I think is normal in other aspects of medicine, but is an issue, I think, with some of the inborn errors. So, for example, if you were an adult person with PKU and you had to choose between a physician and a trained dietitian, who would you want? Let's be clear, right? You want a dietitian and definitely not a physician. And you need to open your mind to different methods of providing care. I'm going to show you one such example. These are data from Amsterdam from Carla Hollick's group, where she took people with PKU and she randomized them to either standard care, And standard care was phenylalanine level got back, or was received in the clinic, then the dietitian or whoever the educator was contacted the patient and said, your level is high, we're going to make this adjustment. Or to a self-management program where the patients were sent an email, your phenylalanine level is back. And then they could log into a password-protected site where they could see their phenylalanine, and there was sort of little algorithms, go up, go down by this. And what she found by this was that that there was no difference in phenylalanine levels. Now, they weren't good, okay? Don't forget these are in SI units, so this 600 here is a cutoff of 10. Adults have high phenylalanine levels, and I never publish the phenylalanine levels from my clinic because I don't want anyone to know, really. But what was interesting is that they didn't get any worse. Okay, they did not deteriorate. This was much more time effective for the clinic, and yet there was no change actually in the level of metabolic control, and the patient satisfaction was actually higher with this approach. They felt invested in the care, so actually nobody wanted to go back to the usual care when the study was complete. Moving on to communication, again, from patients and family viewpoint, they need to understand that the limitations of adult healthcare providers are different from those of pediatric healthcare providers. For example, if a 19-year-old says to me, do not speak to my mother, I cannot speak to his mother. Now, this may astonish you that a 19-year-old might not want me to speak to his parents. Okay, but I cannot actually do it. And also the time limitations are different for adult health care providers, especially specialists. There was a study done of patients with inflammatory bowel disease, and I guess somebody went with them to their appointments, and they found that the average length of time after which the gastroenterologist cut them off in the middle of talking about their problem was 3 sentences. So and then they scope them. So one of the things that we actually do with our patients when they come to us in transition is have them work on a 3-sentence summary. I have PKU, I can't break down phenylalanine, I have to take a diet where my protein source comes from a medical phenylalanine-free formula, right? It takes them several visits to get to that point, but we have them work on that. Also, patients and families, and this is something for which education clearly is easy and can be done. They need to know things like their medications and their allergies. Like, this is just a waste of time for an adult healthcare provider when the patient doesn't know what they're on or what they're allergic to. And we've already heard that the healthcare records do not transfer. Don't speak to one specialist about a problem that belongs to another specialist. This saves your time with the specialist the way you have, but it also means that the patient needs to understand who's supposed to look after what. Okay, and that's a matter of education. On the healthcare provider viewpoint, in terms of communication, you guys, again, you've been looking after this person since she was, 2 hours of life. You have more information in your head than will ever be in a transfer document, even some of the transfer documents that I've received where they have photocopied the entire hospital chart. This was really not helpful. So, pick up the phone, speak to them. 2 minutes, and you can get more information across in those 2 minutes than in any amount of documentation. Also, another thing that you can do to actually enhance the likelihood that that person will show up to their adult health care provider is you can see the patient prior to transition. Actually, this study was done in patients with congenital heart disease, and what they found was that the single biggest predictor of whether or not the patient showed up for their adult cardiology appointment was whether they had been seen in the 18 months prior by their pediatric cardiologist. The adult health care providers have to adapt flexible office practices. This would be things like multiple reminders. So, most adult health care providers, they're going to phone, they're going to leave a voicemail. And that'll be it. You don't show, you don't show. And also, in addition to multiple reminders, you probably have to have some flexibility with rebooking people who don't show. In my province, for example, we've applied to government for certain diseases and for patients in the 18 to 25-year-old age group with those diseases. We've said, give us a fee code for a no-show. Because if the doctor says, okay, well, I know this is high risk of no-showing, but I'm going to rebook him, if he can rebook him once or twice, that is going to enhance the ability of actually getting that person to the adult health care provider. Whereas most adult physicians who are paid on a fee-for-service basis, patient doesn't show, they are out money and they will not rebook. Okay, so this is actually a relatively simple thing to do just by looking at the fee codes. I'm not saying for everyone, I'm saying for certain diseases and in a certain age group. That would help. Motivational interviewing is a tool that we also use, very easy to adapt, where we're trying to see where somebody is at the, in terms of their phases of change. So you're a 20-year-old who's going to college, has PKU, living in a dorm, eating pizza every night, not taking any formula, hasn't told any of his friends that, that he's got PKU. Well, are you going to spend a lot of time with that person? Nope. Okay, because he's not ready to make a change. He says, yep, I'm having a great time, not going to take any formula. Then you say, great, I'll see you in 6 months. All right? You bring him back because at some point he's going to be ready to make a change, but he's not ready to make a change now. It's not worth your time. It's a waste of your time. Whereas if he says, geez, you know, I'm having trouble concentrating when I'm writing my term paper, I think I might want to go back on formula, then that's when you dedicate the time to it, right? So again, in terms of the time pressures being different for adult physicians or specialists in the office. You have to look at novel communication tools. One thing that we have been experimenting with, which is quite fun actually, is having the patients create a 3-sentence summary of their visit. It's fun because you realize how little actually has gone in to their head after the visit. Why do we do this? Well, number one, it is kind of feedback in terms of what they've taken home, but number two, especially for those transitional age ones, when their mom phones and says, you know, what were his phenylalanine levels, and you know I can't tell the mom, right? I can say, you know, why don't you talk to Jonathan? He actually has that information, right? So that sort of gets around two of those problems. And the other thing is you have to really, right from the outset, define what is appropriate communication. So this is data, again, from the kidney disease population, and I'm only going to show you this one thing. 95% of them thought that the most appropriate way to interact with their healthcare provider was through Facebook, okay? So you know, if you're not going to friend your patients, then you actually have to, this has to be established right at the beginning. How is the best way to get a hold of you? I remember reading once in a magazine, just a normal magazine, that there were 3 things that marked somebody as old. The first was that they left voicemail messages. So apparently, young people, if you want them to answer you back, you phone and then you don't leave a message, because then they see the number, but there's no message, and then they're interested. If you leave a voicemail message, they're no longer interested. The second was that you wore a watch, because the young people are all checking the time on their phones. And this is kind of funny, but honestly, I can't remember what the third is, and I think that is telling. There are a number of legal issues about using things like Facebook and Twitter to communicate with patients. I can tell you my institution is way behind the times on this. But so if you are caught in that legal conundrum and you cannot do this, then you need to establish it right at the beginning. How are we going to get a hold of you? Because this is really a big problem. Moving on to sustainability, you know, to get funding for transition coordinators and education programs, right, you have to show that it actually affects outcome, and there's many studies on this. I'm showing you just one. This is actually from my center. And what they did was they looked at patients with renal transplants, and they took 2 cohorts. Those that were transitioned in the 2 years prior to the institution of a transition coordinator who then helped them through, and those that were transitioned in the 2 years after. And they looked at their outcomes, and look at this outcome. This is not phenylalanine levels or urinary gag, okay? This is death or graft loss. And look at the difference in the outcomes. So the difference in the outcomes were so staggering as to more than pay for the cost of the transition coordinator. Similar data actually exist in other conditions, HIV, for example, lots of data on that, cystic fibrosis. So you might think, okay, well, there is no data to support that in the field of inborn errors, but I actually don't think that this is where the problem is. I think that if one just again looks at the example of PKU, I think that the issue of maternal PKU alone is enough to justify coordinated transition support for adults with inborn errors. These are data from Canada that were published in 2008, where they assumed that, or they went through, and there was about 120 infants in Canada born to mothers with undiagnosed PKU. And in fact, there was a call for some selective case finding, because about half of these women that were picked up did not actually have cognitive impairment, so would not have been picked up if one just, for example, screened people who had cognitive impairment. And when we first opened my clinic, so these data are from 1999, I actually costed out what it would take to look after a single one of those individuals, assuming that someone with a maternal PKU would require group home care. And over the lifespan of that child, right, that's $9 million. That pays for a lot of coordinator support. Okay, so I actually don't think that this is the big problem. For the other inborn errors, of course, there's no data whatsoever. This is the situation when you look after people with inborn errors, but one could justify a transition coordinator who could look after people with diseases, including PKU, just, I think, on the basis of these data. We've heard today a lot of the issue of about healthcare providers, and I think this study is really interesting out of Boston. And what they did was they surveyed pediatric residents in the light bars and internal medicine residents in the dark bars about, first of all, whether or not they'd received education on certain childhood onset chronic diseases like autism, cystic fibrosis, Down syndrome. And secondly, once they graduated, did they think they would be likely to accept these into their practice? So as you might expect, while the pediatric residents were more likely to have had education and more likely to accept them into their practice, but the adult internal medicine residents were much less likely to have education and very unlikely to accept them into their practice because they don't know. And so what this group did was they set up something which is called the WISHES program, which is basically a series of online modules for some of these childhood onset diseases that residents could actually work through to provide them with some education. Right? Once they understand that it's not rocket science, then they feel more comfortable and be more likely to take these patients into their practice. I think that this is a strategy that would work very well for certain inborn errors, right? PKU, for example, glycogen storage diseases. I think this is really a good strategy. Also, I think that although the diseases that we deal with, other than PKU, are considered rare, I think the focus of these as rare diseases is not helping. It is not helping the transition into adult health care, because when you tell an adult physician who that day is actually admitting 20 people with an MI that this person has a rare form of congenital heart disease, their eyes are going to glaze over and they are no longer going to be interested. Right? So I think that PKU in particular is also not a rare disease, actually, although it's less common than cystic fibrosis. It's in the same order of magnitude, and yet there are dozens, literally dozens of studies on appropriate transitional planning and care for people with cystic fibrosis, and I could only find one on something with PKU. So I think it's really time to move these into the mainstream. We've heard a lot today about the issues in terms of lack of genetics care providers, ways to extend the genetic care providers that you have through telehealth, etc. But the simple fact of the matter is that there are so few metabolic physicians that most of these people are going to have to be looked after at some point and to some degree in the mainstream. So I think focusing on it as a rare disorder that someone doesn't have to learn about because it's small print, this is not helping us. Where I think the biggest barrier, in my opinion, lies in terms of supporting transition planning for people with inborn errors is that there's no data on the outcomes. Okay, there's no data not only on the outcomes of the transition process, but on the outcomes of the disease. So what kind of outcomes are we looking at? This again, I've gone back to diabetes, but this is a study where they looked at a transition program for people with diabetes and showed that, yep, it reduced their hemoglobin A1C. So the people who had the support of the transition coordinator had lower hemoglobin A1Cs as young adults. But more importantly, it actually reduced important things like acute complications, admissions for DKA, etc. So this is a hard outcome, isn't it? Okay, so you do the transition, and the patient does better, not the number, not the hemoglobin A1C, but the patient actually does better. And this is completely lacking for all inborn errors of metabolism, and that includes PKU. So if you read the PKU literature on adults, they can't even decide on a target, okay? So some groups, a group in Germany, looked at all of their patients and said, guess what, the average Phe level is 15, so that should be the target. Well, just because it is doesn't mean that that's what it should be. No one is doing data that is looking at the cognitive outcomes in PKU. That's what we need, not phenylalanine levels, cognitive outcomes. There are many treatment strategies, as we know, for PKU now, and some of them do not affect phenylalanine levels equally, right? We don't actually have the information, for example, to say that a phenylalanine level, the cognitive outcome with a phenylalanine level of 8 on diet plus Kuvan is the same as the cognitive outcome in phenylalanine level of 8 of diet alone. In fact, there's a lot of reason to think that those two things may not be equivalent. Large neutral amino acids, phenylalanine levels will go up, but the patients might be better. We actually need hard outcomes, right? And when it comes to PKU, it's going to be cognitive outcomes. When it comes to the other inborn errors, it might be death, it might be hospitalization, right? Those are the things we need. And until such time as you have good quality data saying that it matters that you look after the adults with these, it's going to be very, very difficult to convince adult healthcare providers to take them on. So fortunately today we've heard all kinds of plans in terms of assessment, which I think is great, because usually you go to conferences on inborn errors and the tools of evidence-based medicine, or those words evidence-based are really considered profanity. It's not all bad news. There is a single study looking at a transition program for people with PKU. This is out of Germany. And they got feedback from the 44 patients that they transitioned, and there's a couple of interesting things about it. Number one, they wanted the ability to go back to the pediatric clinic after they had been transitioned to the adult clinic. I think this is like going back to your high school and looking at how low the ceilings are and stuff. So if you're going to do this, this is fine, but don't keep them. Right? Send them right back. Say, it's really nice to see you, glad you had a good time, and back you go. And the other thing that I thought was really interesting was that the patients now, they did not want it timed with the high school graduation. So the healthcare team had thought that this would be a good time. Patients did not think it was a good time because they thought it was a time of a lot of other turmoil, and they wanted to not do it at that same time. We ourselves have a 30 question questionnaire that we ask people after they transition. I'm only showing you 3 of them here. And basically what you see is that overall they feel that it's really quite satisfied, so in the white strongly agree. They feel that they've had adequate time with the team, even though they actually do have less time with our team and with the pediatric team. And very interestingly, they feel overall that their disease is better managed, not because it is better managed, we have a really good pediatric team, but because there's more patient responsibility for management, and because of that they are more vested in it and they think it must be better. Okay, so, and their phenylalanine levels are not actually reflective of that. Now, I just have 2 slides on setting up an adult clinic, and I'm going to preface it by saying that many, many people over the last 14 years have asked me about this. And I've had lots of feedback from different people, and many people do not agree with what I have to say. But I would point out to you that there is a huge shortage of clinics for adults with inborn errors of metabolism everywhere in the world. So as Dr. Phil says when he talks to all of his dysfunctional people, what you're currently doing, how's that working for you? It's not working that well, is it? And I can tell you that some of the things that I have to say here, I know are actually the case in the other big adult clinics. The clinic in London, there's a clinic in Toronto, there's a clinic in Sydney, there's a clinic in Melbourne, and this is all, they all have had similar findings. From a pediatric perspective, because these are no longer children, they believe that the resources should come from the adult setting. This makes sense, right? Okay, so the resources to look after somebody, for example, with inflammatory bowel disease as an adult come from the adult gastroenterology division. And they believe, therefore, because the patients are turning 18, that the adults need to get ready for them, they need to set up a program for them, and they need to find a doctor that looks after them. It's not that I disagree with this, but this is completely separate from the way the adults think. Okay? The adult physicians are saying, right now, you are looking after these patients. They are your responsibility. If you're going to transfer 25% of your patients, then you transfer 25% of your resources. Okay? They believe that the resources should come with the patient. They believe that the onus, the responsibility to establish the program lies with whoever wants to get rid of them, and that is you. Okay? Not them. They're not looking for work. That's you. And the physician resources, that actually what you have to do before you transfer anyone is you have to identify and train a physician. And I can tell you that of the successful adult programs that I'm aware of, because there's now an adult metabolic group that is run through the SSIM, in every case, this is what happened. They identified the physician first. They funded the physician first. They funded him for training and also for the administrative time and getting the program set up, and then they transferred the program, right? Then they transferred the people. In my case, I was forced into it, and 14 years later, I'm still doing it. But this is actually have to be where you need to start. And in every case, again, it was the pediatric facility that found the funding for the adult physician. So it's not that I disagree with you. Okay, it's just that this is the way that it seems to work. Maybe there's a better way, a third way, I don't know. So just to finish then, transition, as we pointed out, is a process, not an event, not just the transfer of care. We're not doing a great job currently, and that's because there are a lot of barriers in terms of the expectations of the patients and families and also the physicians on both sides. There are issues around communication which could be helped with more tools and resources, and in particular, I think for the area of inborn errors and metabolism, that the big problem is that what we need is good data on the outcomes of the adult patients, and once you have that data, then it's going to be a lot easier to do some concerted transition planning. Just some resources there. That is the reference if any of you are interested in that PKU transition study. And I'm just going to close. This is Vancouver, British Columbia. It is the most beautiful city in the world. I mean that literally. I mean, we usually win the most beautiful city in the world. And we're usually in the top 3 with Geneva and Stockholm, who are much colder than we are, in terms of the most livable city of the world. And this gigantic thing, which is roughly 6 times the size of Central Park, that's Stanley Park. So come and visit, and I'll be happy to take any questions. Well, I shouldn't say happy to take any questions. I might be frightened to take questions.
And at the risk of being booed by all the pediatricians in the room, I think I absolutely agree with you that the funding should come from the pediatric side. The question is, how do you do that?
Yeah.
How does a pediatrician apply for funding to fund an adult program?
Yeah, well, I can tell you how it happened at my center. It's a little bit of gamesmanship, and that gamesmanship is going to be different at every center. But at my center, the pediatric team, what they did was they went straight to the Ministry of Health, okay, and they said, as of this date, we will no longer follow the adult patients. We need you to fund someone for a 2-year program so that we can train them and start transitioning the patients to them. So what they did was they drew a line in the sand and said, we will not follow. This is very frightening, I got to say, right? Especially when you know that they don't have a lot of good health care. When I say fund the physician too, I think the mechanism of funding is really key. Fee for service and inborn errors of metabolism, this is never going to work, right? It's never going to work when you're competing with residents who want to go to the cardiac cath lab, and make $1 zillion and drive Audis and, those kind of things, right? You actually have to have some, I think, regardless of what your normal payment structure is for adult physicians, I think for inborn errors you have to be looking at some kind of salary mechanism, because fee for service and everyone will starve. Well, that would be me.
Right. So this isn't really transitioning from a pediatrician to an internist. It's transitioning from pediatric metabolic diseases to adult metabolic diseases. And that's actually a great solution, but that's what doesn't exist in 98% of our circumstances around the world. And the issue of transitioning from the pediatrician inborn error metabolism team to an internist without that metabolic component is what I don't understand.
Right, well, that's maybe easier than the other questions you were probably thinking about asking me.
I
say to you that you were saying earlier, right, that as a geneticist, you need to continue to be involved in their care. At no point ever do I think that adults with inborn errors of metabolism should be looked after by people without expertise. There needs to be adult clinics. There are adult cystic fibrosis clinics. There are adult thalassemia clinics. There are adult inflammatory bowel disease clinics, right? What has happened, though, is that I think the field of inborn errors, probably because in the past many of them didn't live to be adults, are behind where other chronic diseases are in terms of saying, yes, there is a need for adult health care. And I think one of the reasons that seems to be difficult in terms of moving forward for this is that I'm not actually sure, present company accepted, I'm not actually sure that all of the geneticists looking after the patients believe that anybody who, other than them can look after these patients. I think that that's wrong. But I agree with you that what we are actually talking about is expert care. There's no way somebody with an inborn error can be looked after without the team, right? Why would you ever think that somebody with maple syrup urine disease could be transitioned to somebody, to an adult internist without a dietitian? Crazy, right? Have to be the team. That's why I say the resources need to go with the patient.
Right, and so that team only exists currently in most places as a formerly pediatric nutritionist team group, if you'd like, a metabolic nutritionist team group, which has then got to move along with those as they become adults in partnership with an internist who's willing to take care of the non-metabolic internal care, internal medicine issues. But if there's not a clinic such as yours, as there isn't in almost every place in the country, in the world, then we don't have a clinic such as yours or adult metabolic people to transition these patients to.
Right. Well, first of all, I disagree with you. I actually don't think that the pediatric dietitian and other support teams should move along with the patient. The adults are not large children. The children are not small adults, and the nutritional needs of the adults are actually completely different. So what you actually need is somebody who knows something about adult nutrition and also inborn errors.
But that doesn't exist.
Well, it does.
So if that doesn't
it
exist,
does in
what's
many
the solution?
places, and in fact, in the United Kingdom and in Europe, they actually have degree courses in adult inborn errors. Right. So there are actually people. This way came after me, so I'm not one of them. But actually, people certified in adult inborn errors. So that is, I think, what has to happen. And I'm not trying to slag the U.S. or anything coming from Canada, but the Americans, you guys are a little behind on that.
We're completely
right?
different.
No.
It doesn't exist in that way.
But
well,
you're behind.
Like,
you're behind in
but,
pushing for it. Is what I say. Push for it. Say
because
we need
our
adult
internists
metabolic
aren't
specialists.
interested in becoming adult metabolic internists. In my so. Okay.
Yeah.
Well, there's not a one in Louisiana or Arkansas, or there's one in Mississippi. You're right. Pardon me. But the point is that there are hundreds of these patients.
Yes, I know.
So I think what you're saying is you're advocating for a solution that maybe you guys have created in our country, but we're not to the point where we can do any of this because that thing doesn't exist to go to.
Oh, I completely disagree. You have training. Sorry.
I just feel like we have big gaps. We do have big gaps here. From dietitians' point of view, I hate to tell you, Hans, we don't even have pediatric metabolic training, even for dietitians in this country. They're trained on the job by whoever the person is. We have pediatric nutritionists. There's no such thing in this country. So every dietitian who starts coming to work is like an intern for first 2 to 3 years on the job, you know. As far as physicians are concerned, I'm not sure what we have done to recruit the internal medicine. Right now, we have 2 fellows in internal medicine who are being trained in biochemical genetics. So I'm not sure we have even, I don't know what we have done. So I'm glad that dialogue has started for the need, and there is a gap, there's a shortage, but there's no clear plan still in this country, and we need to talk about it. And I'm glad we're talking about it.
And I think, in
And
terms of
hopefully somebody will fund and start putting it on the agenda.
in terms of the training programs, for example, even in Canada, you can get into biochemical genetics training from genetics or from pediatrics or from internal medicine. But if you go in from internal medicine, they make you spend longer than if you go in from pediatrics or from genetics. Why would that be? That's crazy. It's a disincentive, right? So you incorporate it into your training program. You have subspecialties just like you have the other things. But what I think is unrealistic is to expect your Joe average internist who's out there dealing with diabetes and cholesterol and hypertension to say, oh yeah, sure, send me your patients with maple syrup urine disease, right? Why would he spend the time, right? So you find a physician, you train them, and you pay them. That's how you get it done.
Just to call. Can I speak? Just to
Please.
calm down the tension.
Yes.
I don't have a question. It's more like a funny and true story and an information that only few people in the world knows. Since we're talking about transition and the barriers for transition, and sometimes there's a growing attachment between the patient and the doctor. He doesn't want to leave his doctor to another one. I'm from Saudi Arabia. We have a very well-known prince, one of the wealthiest guys. I'm not going to mention his name. The biggest Boeing that's decorated with gold inside. This man has his doctor that goes with him everywhere. And guess what? He's 55 years old, this prince, and his doctor is his pediatrician. He used to treat him since he was 10 years old. The pediatrician is very old now. He wants to retire, and that prince doesn't want to let go of him. So I just wanted to mention this story. Thank you very much. Yes, it's true.
Well, I think the wealth of a Saudi prince would go a long way to helping this problem, probably, but yeah.
I just wanted to bring a different point of view. Sure. I'm an adult with PKU. I'm 30, and I've never been a day off diet.
So your levels are not.
It's an accomplishment.
15, yeah.
So I just wanted to beg to differ about the face it, adults have a level over 10, but I'll let you have that one.
Yeah.
I've never had one over like 7 or 8. So I really appreciate everything that you said, and I think there is a huge need for it in the United States. I love my clinic. I named my daughter after my clinic. But I did. But I really feel like that there's a lot of fears that I have about getting older because I'm one of the oldest people I know on diet. Well, am I going to develop type 2 diabetes because I have such a high sugary diet? Am I going to have osteoporosis? Am I going to have all these other health concerns that other people are like, oh, take a vitamin, or oh, just drink more milk? And I can't do that. So I need a dietitian to more focus on my long-term fears about my health. So I think it's awesome, and I wish we could get something started here.
I haven't had anyone name any children after me. I must be failing even all of the PKU babies that we've had. So, thank you for your comments.
I have just a quick question. I understand the logic about transfer resources with the patient, but where do you get the funding for that? Where do you get the funding to pay an adult physician?
Well, again, as I said, I think it's going to differ in every jurisdiction. But until you get it, can't move forward.
I mean, we have no way to do that. We have no way to do that.
No, well, I mean, I think, again, when I come back to the answer of needing to draw the line in the sand, right? I understand that the challenges of that are different county to county in the United States. And actually, they're slightly different province to province in Canada, although that kind of thing is more centralized in Canada, as you know. But that is actually, I think, the first step that you need to make.
It makes sense. I just know that we don't have the ability to obtain adequate funding to do what we do within our center, much less train somebody else. We don't have it. There's no way to get it.
I think, do you have a comment?
I was just going to mention the Medical Biochemical Genetics Fellowship is helping to train these internists, and we've had 2 of them already. I think Ronnie has a similar experience. Yeah. It's the clinical training they're going through, not the old laboratory fellowship, right?
I just wanted to bring up, I think the problem we're talking about is a good problem because the life expectancy for most of these chronic illnesses has gone up over the past 20 years. I mean, in my lifetime, and I'm one of the youngest ones here, I have seen sickle cell disease patients live longer. And so it's an evolving problem. I don't think it's anybody's fault. It's not the adult's fault or the pediatrician's fault. I think life is changing, just like social media is becoming a big deal. They're growing older, and we have to kind of train with them. And I think it may not be out of the box to think about a co-fellowship and between a pediatric and an adult training where you train to take care of that specific age group between 18 and 30 or 18 and 25 to kind of fill that niche. But we need to start thinking about how can we do this in a non-traditional manner. I don't think general pediatric hematology or pediatric oncology should be that. It should be peds, young adults, and adults because they are growing older. And there's nobody out there who knows enough to take care of these older patients. There are very few people out there.
There is actually literature on that, actually, people that they variously call them adolescent health specialists or whatever, but basically their specialty training or subspecialty training is actually to focus on that transitional age youth, not the disease, on the age range.
Just to follow up on that note, in America, probably half of the accredited slots for biochemical genetics are currently open.
Huh. Phew. Well, thank you very much.
Thank you so much. It was exciting to see this debate even at the end of such a long day. I have no other further comments, but want to thank you for staying and for a wonderful discussion. And I hope we continue to stay connected rest of the year before the next meeting. And we have 2 exciting dates of further planned for more content-oriented meetings in terms of the genetics content. So hope to see you all next couple of days, and the reception is there at 6:30. So thank you again.